will move to the felicitation ceremony, for which I would request the dignitaries on the stage to felicitate Dr. D. Nageshwar Reddy,
Although you said you're only a standing person, I don't think you're a standing person. You are the heart and brain behind all this, and it's extremely difficult to organize something like this because of complexities involved in terms of patients, transmission, audience, and so on. I think you put all this together very nicely, and this is I think a good example of teamwork here. Your team is very good, and I will congratulate you on this. Very good achievement. I think Palani knows very well how difficult it is to organize. He frequently organizes this conferences, so it knows how difficult it is. So I think it's a very good effort. And the second, of course, to compliment you on this uniting effort, you tend to get everybody together. It's very unusual to see all the gastroenterologists in the city coming together and sitting like this on a busy morning without going for their practices, and that itself is a big achievement. I think that is something that is not very commonly done. At the same time, I also like to compliment Bhaskar for setting up this auditorium. I'm just telling him that this is like a 5-star hotel auditorium. Now, most hospitals, corporate hospitals especially, don't want to spend on auditorium because it's not very cost effective in terms of returns, but he didn't look at it, he looked at long-term education ventures, and I think this is a very good thing to have in the hospital, and this is a real added advantage. Endoscopy in India is actually now rapidly coming up. There are now approximately about 5,000 endoscopists and 5,000 centers doing endoscopy in the country. It is done both by surgeons and physicians. And what we require in our country is that this progress in endoscopy should be uniform, so that we should actually apply what is happening like in the West, certain protocols, so that every patient who comes to an endoscopy center is treated in that certain protocol. Unfortunately, in our country, because of this varied experience, what is happening in Bihar may not be happening in Hyderabad, or what is happening in Delhi may not be happening in Lucknow. So a lot of variation is there. So the Endoscopic Society of India actually is making a lot of effort to try and create uniformity in endoscopy. And one of the ways of doing this is to set up certain guidelines So many guidelines are coming on how to wash the endoscopes, how to prevent infection in patients, and so on. In addition, guidelines are being set up now by the society and including the World Endoscopy Organization on how endoscopy center should be set up, how many rooms should be there for this amount of workload, how many. So all this is getting uniform. But what we require more in addition is an educative experiences like this, and this is a good effort because this is a exchange of ideas occurring between several endoscopies, so that what to do, what in a special situation, like for example, you see a stone in the bile duct, what are the various approaches that can be done? What is best for our patient? Because what is best for our patient is not necessarily what is best in, say, the Western countries. So we should innovate, change our techniques, make cheap technology available. Not cheap technology, but actually technology which is done cheaply for our patients, so that you get the best of what is available in the world, but done in a cost-effective manner. And this is the main aim that occur. And I think these conferences and workshops help to create this type of atmosphere, so that we can freely exchange ideas. So I'd like to again congratulate the team here for this excellent effort. Thank you.
MD and CEO Dr. Bhaskar Reddy, Dr. Nagi, Nagarajan Kumar, friends. I'm really extremely happy to be here this morning. I again wish to congratulate Dr. Nagarajan Kumar and the team for the very good effort, excellent facilities. And this from morning, I think you'll all agree with me, a very good demonstration of diagnostic and therapeutic procedures. And also I appreciate the efforts by Dr. Nagarajan Kumar to bring in the entire gastroenterology fraternity from Hyderabad this busy morning, working day. It's very difficult to get the same sort of group in Chennai. I really appreciate your efforts. That shows the love and affection towards you from the colleagues. And the workshops of this sort of magnitude are very important. Apart from imparting knowledge to the delegates, and also it helps the practicing gastroenterologists doing the therapeutic procedures to improve their technology. And also for the Department of Gastroenterology and the endoscopy, conducting such workshops will help to improve their confidence levels in performing complex procedures, and also the technicians and other nursing staff will also be to develop the skills better and perform better. So with these few words, I would like to again congratulate Dr. Nagarajan Kumar and wish this workshop and the conference a great success. Thank you.
Dr. B. Bhaskar Rao, and can we hear a round of applause for him, please? Thank you.
Good afternoon, everybody. On behalf of Krishna Institute of Medical Sciences, it's a great pleasure for me to invite all of you here and to attend this workshop. And before talking anything, I should be able to congratulate my gastroenterology team, Dr. Nagarajan Kumar, Dr. Sharath, Dr. Nitish, and the surgical colleagues, Dr. M.B. Prasad, Lakshmi Kant, Srinivas Prabhu, Shastri, and Suresh Kumar. These people's last couple of months, maybe even more, our business development team keep on saying time is not enough to work, and Nagarajan Kumar is insisting Dr. Nageshwar Reddy's time is not there, so we must do it, otherwise it will go into the next year, and then the auditorium will not be ready. So somehow we put all efforts and made it a good success. So I must congratulate the three teams, one the civil team and the EDP team and the gastroenterology team and the business development team. If you look back, we are all about 30 years back we did our MBBS. At that time we haven't seen these endoscopies, these workshops, or these type of advanced technology. KIMS is being a 1,000-bedded hospital with all the specialties, you name it, in medical field, it's available in this hospital. That is the one reason the technology is improving day by day, and based on the technology, the diseases are also competing with the doctors, who is going to be successful, whether the disease or the doctors or the technology or the pharmaceutical company. So when we want to be updated, it's not only the experts all the team that joins in this institute should keep on upgrading their knowledge, and not only with us, internationally, nationally, and we need to group all the specialists in their own fields, join together and exchange the programs and improve, and finally we should pass it on to the benefit to the patients with a less costly expenditure on the patient. That's why I think there are so many innovative ideas has been developed by our Indian colleagues. You might know that even some few lakhs which cost, and Nageswar Reddy could be able to do it even few thousands without causing any quality of the care to the patient. We have seen the outside, there is a simulator which is they are saying about 1.5 crore. Even to train a proper medical student on the endoscopy, colonoscopy, ERCP, and we were just thinking that he is planning to do it for even 5 lakhs, so that all these equipment can be utilized in all the medical colleges, so that what we are doing today, it can be practiced in the medical school itself. So the syllabus and the technology and everything is there. We need a lot of innovative ideas we need to develop. This is the way we have invested a lot of money on this auditorium. As you rightly said, see the investment which gone into nearly 5 crores. We feel that it may not be able to make anything for a corporate hospital, because corporate hospitals always looks return on investment. But unless we don't have a proper knowledge by our juniors, by our colleagues, including the paramedical staff, this is going to be a structure or a spine for the entire medical fraternity tomorrow to serve a good quality care provided to the patients. Previously, when we started about 10 years back, we put about 120 bedded auditorium. And I thought it's a lot of wastage of money. Now I see people are fighting for to book the slots, so that the amount of awareness, the amount of, it is not only medical technology and the medical workshops, even the people who are working for the patient, like the paramedical people, the nursing. Today we have NABH accreditation, tomorrow we may get a JEC. So many things we need to be updated. It's not only on the technology front. If you want to give a safe patient, the patient should feel comfortable when support given by all the senior faculty of the gastroenterologist in the Twin Cities, and even the national faculty, Swami, and then international faculty who have come here all the way and spending. It's a good thought process. All of us should be able to meet every month and exchange. It's not only the senior people, you may not get this type of opportunity for the people who are, especially the undergraduates, the postgraduates, or the beginners of the gastroenterologist who wants to try to get all these specialists in one platform and discuss with them and see live how they are performing. The people who are doing, when they are doing really, you can able to learn a lot of skills. When you learn these skills, it will be useful for the patients again, ultimately to pass it on. So once again, I congratulate all of you and continue the today and tomorrow with the same enthusiasm to learn and exchange. In this workshop, one more thing, sometimes the senior most people also will be learning. Even though I practice about 30 years of cardiothoracic surgery, still I can learn from my residents and registrars. When you give the opportunity to exchange the ideas, that is the whole theme of the workshop. Thank you very much.
Which is different from the dilatation balloon that we use. This balloon actually is for extracting stones, or you can use it for occlusion also, occlusion cholangiogram also. Balloon. Yeah, you can, balloon is passed on the guide wire. This is like the angiography balloon that the cardiologists use. This is a critical part of this procedure, that you must demonstrate that you have completely cleared the CBD. Otherwise, some fragments remaining will cause problems. So we have to demonstrate that very clearly. So I'm going to pass this balloon up there. And as I'm doing this, Kishan is giving a gentle traction. And just 1 second, I just pass. Sometimes, yeah, now the balloon, you can see the balloon endoscopically going in?
Yes.
Okay, now the balloon goes up right at the top on fluoroscopy, you can see it.
Yes,
now we'll
yes.
get some contrast. Kishan will get some contrast.
Yeah, can you show, Ramesh, can you show that two black points?
Yeah, so the two black points are in between the balloon is in between those two black dots that you see. Can you get some contrast? Not in the balloon, no? This is over here, yes. Inject here, and we'll follow the contrast. Inject some contrast. So this is a balloon which is coming from, I think this is a Wilson Cook balloon. Yeah, Wilson Cook balloon. Yeah, so contrast.
Nice.
Now contrast is injected. Now inflate the balloon. Inflate the balloon so that we are right. Yeah. Inflate the balloon to half. Inflated? Yeah, cool. See, now the balloon is inflated.
Nice.
And then now I'm going to pull the balloon down. As I pull the balloon down, inflate some contrast also. Fix the balloon there and inflate contrast. Now I'm going to pull the balloon down. And as I'm pulling it down, inflate contrast. You can see some resistance is there in that area. I'm going to now, there's some pus-like material coming out indicating that there was some obstruction earlier there. Yeah. Now deflate little because there is a junction. The balloon is very tight there. Deflate little. Deflate little. Okay. Deflate little. Okay. Little. Yeah. That's okay. Now inflate. Now inflate. Now yeah, inflate. And then yeah, same. Then we keep it. Okay. Yeah. And we're coming down. Now can you go down part? Can you show the down part? Keep the inflated balloon. Keep it inflated. Now I get the full balloon. Can you see the balloon coming out?
Yes.
It's clear down. You see a lot of air and all is there. It's totally clear. Okay?
You require to send it, sir, or you don't require?
No, not necessarily.
The pus is coming.
Pus is coming, but I think because it's clear now, everything is slowly drop off completely. Okay?
Suppose, is there any maneuver to extract the stone, sir? Balloon sometimes it doesn't come when.
Yeah. So the best technique for the balloon is that this is a wide sphincterotomy. Otherwise, what we'll have to do is that we actually do the technique where we don't pull the balloon out, but turn the scope down and push the scope down. So you're in the angle of the CBD, then the stone drops out nicely. But this is such a large sphincterotomy, the stone came out very easily. Okay? Any further questions there?
Panelists, any questions, comments you want to make?
Dr. Reddy,
Yeah.
there is a 3 centimeters balloon,
Yeah.
dilating balloon.
Yeah.
Do you think it is advantageous than the 5 centimeter CRE balloon, or would it replace the future for CBD dilatation?
For 3 centimeter, even a shorter balloon, yes. The new balloon that's coming up actually is 3 centimeter length, not 5 centimeter, because the shorter length is much better to stabilize this balloon. And the second change in the balloon that's occurring is that the central part of the balloon is getting a small waist. And the small waist is going to create stability so it doesn't move up and down. So the new balloon that's coming has the 2 features, shorter to 3 centimeters like you suggested, and a waist in the center.
And regarding, because such a large stones can be removed,
Yeah.
and what is the real level where you say, okay, you stop at this level, okay, we think of another option like surgical option or laparoscopic exploration?
Yeah, so now I think very few stones will go for CBD exploration or open cholecystectomy, because as you can see, even large stones like this can be removed. Even if the stone is more than say 2 centimeters in this case, you can still use extracorporeal shock wave, or you can use a sky scope and actually do an EHL and break the stones completely. So even large stones can be very easily removed, there's no problem. Nowadays, the indication would be if you don't have these facilities, or if there's like for example a Mills syndrome, then you want to go in and then in that type of situation, maybe it's much easier or economically better for the patient to have laparoscopy and removal of the stones which are partly in the CBD, partly in the gallbladder.
I think we are seeing more and more lab CBD explorations and open CBD explorations. Only indications have been when there is a high diverticulum not able to enter the CBD and all the situations. So in your experience, like what situation do you really wanted to surgeon to?
You mean technical failure of ERCP?
Yes, yes.
The technical failure of ERCP can occur in some cases when because of either say a patient has a previous dural ulcer with stenosis or for some other reason they are not able to actually get into the papillary area. Once you get up to the papilla, cannulation failures can occur again because of very stenotic papilla or intradiavicular papilla. But generally these are very less, and even when they occur, we generally do a combined procedure. Radiologist passes a guide wire, comes up to the papilla, we take it out, and then we can open the papilla easily. So failure rates with ERCP are less than 3 to 4% now. And when you fail in these cases, of course you go for laparoscopy. But there are some centers which are very good at laparoscopy and the ERCP is not very strong. In these centers, laparoscopic surgeons, especially when there is a bile duct stone with a gallbladder stone, they feel it's much cheaper for the patient to do a single procedure rather than ERCP and laparoscopy. So there is a debate about that. But in most centers where expertise is available, I think we prefer to do ERCP first and then lap. I think agree with Michelle.
Yeah. Completely agree with you.
So can you use CRE balloon dilatation when there is a periampullary diverticulum?
Yeah, CRE balloon can be used safely in this periampullary diverticulum. There is no problem. The reason is in periampullary diverticulum the lower CBD sphincter is very lax. So it opens up very easily with with CRE and chance of perforation is not very high.
And we had two instances where cases were referred to us for perforation following just while trying to do a CBD exploration in the sense ERCP wise. So what advice you like to give, because youngsters to be careful with what stones, because like you are an expert, I think you will be able to do any stones and everything ERCP wise. But for beginners, what advice you like to give? When to stop and when to say okay, you are not able to do it, let us think of there is a lot of edema, you are not going to go in, wait for 24 hours again, try again, or something like that.
Yeah, no, that's an important point. I think for the endoscopists, especially those doing ERCP, it's important to keep the ego down, because what happens is if you can't do, you want to do something in a dangerous situation, so best is to hold back, come back next day, because sometimes the papilla becomes very edematous, very difficult to get it, and you find that after 24 hours the whole thing, edema comes down, it's much easier to go in. So if after say half an hour of trying to do an ERCP, you can't cannulate the papilla, can't go in, you don't have the expertise for a pre-cut, then best is to hold back and come back after 24 hours. But if you have the expertise for a pre-cut, you can do a pre-cut and enter into the CBD. And also if you have a lot of experience with EUS, then under EUS guidance you can cannulate the CBD and then you can actually get into CBD. So all depends on the expertise, level of expertise, but it's always important to remember that even for the best endoscopies, there's a day off when you can't get into the CBD.
Actually, once the opening of the CBD is very large, it is very easy to manipulate the mechanical lithotripsy.
This mechanical lithotripsy is prepared, you are into very mechanical lithotripsy. Then what's the point in directing the CBD to 1.5?
It actually helps us to facilitate us to do it faster actually. It is very easy to cannulate with a mechanical lithotripsy when sphincterotomy is very large actually. Small sphincterotomy, sometimes edema, it will be very difficult to handle this mechanical lithotripsy. And when you start using mechanical lithotripsy, you will know the difficulty actually.
Even without the effort of
I think any difficult CBD stone, first step is CRE dilatation. If you are not able to extract, next step is mechanical lithotripsy. Because this mechanical lithotripsy is not freely available in all centers, and also basket is very costly. Each basket costs around 25,000 rupees. And
there was one of the indication to us, very large stones, more than 2 larger stones, because you need to use one or two mechanical because they often break when you're doing it. That's also one was indication to refer, because 2 big stones you're not able to remove it. I think you better go for surgical option. So what is your experience with that? So you think too many big stones, they are not going, even though you can do it, but the cost of the lithotripsy is going to be very high. You still want to refer for a surgical option.
Very large stone, usually we fail by CRE balloon after 2 million, we usually refer to surgeon. or else patient can offer, we refer to a center where these facilities are here. Any comments from the panelists?
See, to end again, you can come up with what are the guidelines, see, because see there are after how many ERCPs you try all the type of stones, or there are a lot of guidelines. See, I think they are not going to follow guidelines because you are expert people like them, so they can remove any stone, any size, any number of stones. See, whereas in laparoscopy, a big stone, see, we dilated more than 1 centimeter, we don't even return laparoscopically. We say, okay, better to go in. If there are multiple stones, again, laparoscopy becomes very difficult. Multiple small stones, sometimes you can miss stones. So the same way, coming to the guidelines, what are the clear-cut guidelines with stones? See, I think, forget about the expert person like Manmancha, you can do everything and everything. So what are the clear-cut guidelines to say when we will go endoscopically, when we will switch over process?
Voice is not speak louder.
Sir, I have my own setup. I am working in a periphery center. I don't have very good backup. Usually, I do what I do is with small stone, then I do spectropy, balloon extraction. That's why if the stone is large,
That depends on your expertise. If you are confident of doing it, better make an attempt. And we know after maybe doing ERCPs for 2 years, you know which cases you can do, which cases you cannot do. And another thing, round stones or oblong stones are easy to remove. Like bullet-like stones will be more difficult. Irregular stones will be more difficult to handle.
And sometimes there are flat stones, very flat. They don't come out with ERCP. When we do a CP expedition, the stones are actually very flat. They really feel why they have not come out in ERCP, because they are not very big, very flat, but constantly they have been in the CVD, but they don't come with either balloon or what. So when we open, why it was not possible in ERCP. So do you have any experience like because of the size of the stone, location of the stone, it becomes very difficult for you to remove it?
Sometimes when there is a stricture in the CVD, lower CVD, it may be difficult to extract actually. Nowadays this scenario is changing actually with widespread use of CRE balloon dilation. Most of the stones are coming out very easily actually nowadays. But only thing is whenever there are strictures associated and stone above, then it is very difficult to extract it.
MRCP also will help us in identifying the associated strictures. So before going for peripheral.
And what we have seen is many stones which have been missed in MRCP. Now with the endo ultrasound which our colleagues are doing, they are able to identify, because LFT is abnormal, MRCP is normal, but endosono they say the stones and then they do ERCP and they are successful. I think nowadays with the advent of endo ultrasound, the success rate of identification of these stones have greatly increased. I think
especially MRCP with the normal.
You can see some pus coming out. And
because we have endovision in the endo this.
Yeah, okay. Endovision, please. Santosh, can you use history meanwhile?
Are you already in?
Yeah, I'm in already.
Fluoro is affecting.
Yeah, I think fluoro is showing. And that will show EAP. Fluoroscopy also they want.
Now, can you tell us what is the case actually? What are you planning?
She is a 30-year-old lady.
Your voice is not clear. Just
Okay, what I do is I'll tell you the history. In the case of private surgery conjunctivitis, and this dominant structure is there in the upper CBD, for which they have taken multiple brushings. Earlier, brushings for negative for malignancy. Now they put a stent, and she came back close with a stent block and cholangitis. So now the plan is to remove the stent already of the fluoro, of the record, and then what I'm doing is I cannulate the CBD, upper CBD, and you can see the gallbladder. And what I'm trying to do now is take brush attach from the stricture and then put a stand.
Do you have a MRCP film of this patient?
Do you have?
MRCP.
MRCP is there, but can you shoot to the camera? Yeah, we're trying to show you the MRCP picture. So, well, what I
The
do
position of the camera is not good actually. We are not seeing both endo and floor actually. We are seeing view only.
yeah, remove the whole endo, you want to show me, whole endo and fluoroscopy.
Fluoroscopy is more important here.
Yes, yes, fluoroscopy. You're able to see it?
We are having only endo.
Okay. Fluoro image, please.
Yes.
Yeah. You can see that now?
Yes, yes.
It's nice now. Yeah. So thank you. So what I'm trying to do is already I passed a brush for brush cytology, and you can see the.
Can you show where is the stricture actually? We are not able to
this is upper CBD. You can see the file. This
Can you
gallbladder.
put some?
No, I want. Contrast you can give. You can give some contrast. So because already I'm doing the case, so the contrast must have got drained off. So in the case of primary fluid cholangitis with multiple strictures. So the point of doing this case is to remove the stand, take brushes from the stricture area. That you can see. Yes. Yeah. Pandu?
Yes, yes.
The stricture you can see, a short stricture there.
Okay.
Okay? Enough contrast. Because normally we don't give much contrast once I suspect a cholangitis in case of primary fluid cholangitis. Because in PSC, we will not be able to drain all the segments. That is the thing. Now what I'll do is, quickly, I'll take some brush cytology. Brush. I hope you can see that brush coming out. Because the difference between other fluoro and this fluoro is, other fluoro will give you a direct connection. But here, what we are doing is, we are focusing with the handicap and showing you. So the fluoro image will not be that great. Okay? Yeah. Take cytology.
Tell us something about the brush.
Yeah. So what we're trying to do is, I put the brush across the stricture and taking multiple brushings.
This is which company's brush? Microvisor?
No, this I think is Cook. Yeah. Okay.
What the guidewire brush?
Yeah, what the guys are.
Another thing, there is a new brush has come with an US endoscopy, which is supposed to be extremely good because of the probably the manufacturer says it's far more superior than the present existing brush cytology.
Okay.
From the US endoscopy, the new brush.
Okay.
But any biliary brush is usually the output is about 50%.
I know.
Now, how useful it is?
Yeah, how
for
useful it is.
in a student or in diagnosing malignancy.
So, I don't know, he has to tell us. Maria, how useful it is? I'm not aware of that particular brush which you are talking about.
It's a new brush from US endoscopy that has come into the market.
So can you show that brush?
We are doing a study with this new brush compared to the original brushes available with both Boston and as well as Cook.
See, Murali, what we are trying to do is, we'll show you the brush and Pandu.
Yes, yes.
Yeah, what we are trying to show you is making the slides with the brushing what we are taking. She's doing the slides. Okay?
What I heard from the Asian Institute of Gastroenterology, they put this in a cytolite solution and get some extract of the cells to get the picture better, not only the slides. You just rub this into the cytolite solution, and you can gather some more cytopathology and.
Okay. Yeah, I think that also is a good thing, but what we are trying to do is only slides we are making today. Okay? Yeah. Now we are taking brushings. Now what I do next is, I'll put a stand across the scale. You can use a dog test and use dog.
Yeah. Okay, what we have is we have a stand available. And normally I prefer to use straight ones. But now we have a level with there, even that can be used. So,
No, actually, do we agree that histopathology is extremely important when there is a stricture to define whether it is a malignant or not? If you know that there is a malignant stricture deep in the entire treatment would be completely different. Now you know that this patient is a transplant patient. Suppose it is a benign or tuberculosis, maybe it's a simple dilate and put some chemotherapy and then it will subside. If it is an influenza stricture, it makes a lot of difference from the malignant stricture. The only way that you treat malignant stricture for this patient, if it is happen to be malignant stricture, is probably transplantation. Liver transplant is going to be the answer.
okay. So what would the light, this slight delay is there. We're trying to get a straight stand. Yeah, straight stand, okay. So what we're trying to do here is to load the stand onto this. Yeah. Just show them the assembly. Yeah. Can you see this?
Yes, yes.
So what I'm trying to show is,
Can you just explain how the pushing system looks like?
yeah, the purple color is pusher tube, the black one is inner tube. So what we did is, the blue one is the stand. So we put the stand over the inner tube, and what I do is, the inner tube I pass it over the guide wire. Then what happens, then once it goes into the by that, we can deploy the stand. Start with this.
Whether they are more focusing on your face.
I don't know why they are doing it.
Nagan Kumar, I think the C-arm need to be little changed so that the way you're applying, they can focus on the endoscope entering into the mouth. That will be more,
I know. The actual what happened, what for this workshop?
Oasis, sir?
Yeah, this is oasis.
Okay.
See, what this workshop, what we did was, we brought a C-arm from the extra C-arm for a standby. So I'm doing the other room. What Ian did was in the proper endoscopy suite, which we use routinely. So there everything is, well versed with. So that's why I have some
You're
difficulty.
using a 10 French straight stand.
What is the size of the
10 French straight stand, 10 centimeters long.
And 10 French, 10 centimeter long straight.
But this, don't you think that 10 centimeter will be short enough for to cover the stricture?
No. This is, see, look at it, it's below the quota, above the junction of the 60 dot. So, we are sure, we'll see in a minute, we're going to cross it, I'm sure. Yeah. That's what I'm telling you is,
Yes. Ramesh, can you show the stand passing on the stand?
It's down. Is the on the back side of this? Yes.
straight. Oh, push on.
That is the marking on the catheter.
Can we have external camera also simultaneously? I mean, endovision.
Yeah. Okay.
Sorry,
Your endoscopy view.
Yes, yes.
Can we have endovision?
Able to get it?
No, we are seeing the fluoroscope. We need, we just want to see the endovision also.
Yeah. What tells me is time is up, so yes, to do it fast and come out. Then take out the guide wire, pull the guide wire straight.
No, before removing, we want to have an endovision.
Yeah. Pull your cube.
We don't have endovision. We just want to see the strength and then the color contrast of.
Deploy. But this is a difficult case because of now I'm putting the stand.
No, we just saw the endovision for a fraction of a second and then it disappeared in the.
Yeah.
We want endoscopic vision, huh? Yes. You could see now in the blue one and then you can see the flap.
But did you cross
The pusher, yes.
Yeah.
and you're pulling out the inner catheter.
The endo is falling on the stricture actually.
No,
Yeah,
no,
yeah,
no, we cross it, boss. I mean,
No,
The
cross
endo
it.
is pushing to one corner.
Endo image is falling on.
The transmission people please push, keep the endo image to one side, not in the center.
see, as Murali,
yes.
as you pointed out, see,
Yeah.
the point I think now is clear to you. We draw the stricture,
Yeah.
okay?
Where do you require any Sohendra's dilator?
Pardon?
Sohendra's dilatation is required. Sohendra's.
Sometimes we require it, but this case it looks like a short one, pliable one, so I just went across with the temporal stand directly.
No, why can't we do balloon dilatation and put 3-4 slides? Because patient is getting with symptoms again.
Yeah, that also can do, but this is a dominant stricture, so I thought I'd just mainly take care of this. Because it's off camera, so I checked the ERCP. This is the only stricture which was seen nicely. Other strictures are in the periphery, in the second, third degree of bypass.
Are you planning for transplant this patient?
Yeah, this is a good case for transplant.
Because the incidence is almost 97%.
Yeah, almost more than 70% of them inflammatory bowel disease patients. So we need to be doubly sure that these patients are having a ulcerative colitis or not.
If the stricture is malignant, can we still go for?
But if you still have a strong suspicion of malignancy, then your endoscopy is not good at telling you that there is no cancer. So in some of these patients, you might also have to defer transplantation, or you might have to take them off the list.
Transient elastography is a new modality. Has it got any role in evaluating these strictures?
I think I personally don't have much experience with elastography. I think if Sandeep is in the audience, he might be a better person to answer that question. But I think with a biliary stricture, I'm not sure of the role of elastography, because I'm not sure how well you can compress the lesion. To get a good elastographic reading, you need to compress the lesion and then find out if it is hard or not hard. Essentially, that's the underlying principle of elastography. If you have a pancreatic head lesion, for example, then you might be able to better compress that lesion. And you have to use it in combination with contrast EUS. I think elastography on its own may not have a good negative predictive value.
You can, with fair degree of fertility, you can differentiate, although you cannot take a tissue from there. If the bile duct architecture is still maintained in a three-layer structure, which may be thickened and uniformly thickened in a benign structure, but maybe eccentrically thickened, or the loss of the layered architecture, then that would indirectly suggest that there could be malignancy online.
Any role for spyglass in these patients? Come on.
Yeah, spyglass is one of the, I think more than EUS, whenever we find a stricture, most of the time they are sclerosing variety. There is no mass, but there is only pathology lying in the duct wall. So it is better to evaluate endobiliary imaging rather than coming from EUS, because EUS got a very limited role. Spyglass definitely has got role, because if you add any type of cholangioscopy on ERCP, the yield increases from say 50% to 70%. And there are certain classical features seen on cholangioscopy which is 100% specific for malignancy, especially when you see a neovascularization, especially using cholangioscope with the ability of MBI. So these type of scopes, if you can show neovascularization by any means, let it be cholangioscopy or even a newer modality like confocal endomicroscopy also, which shows dilated tortuous vessels, they are very highly specific. So specificity increases tremendously if you use this, but certain features like nodularity or mass-like lesions, they are not very specific, but they are definitely more common towards malignancy rather than on benign lesions. But if you rule out that there is no nodularity, no neovascularization, then yes, you are dealing with a benign strictures. So definitely yes, cholangioscopy is much better than EUS in such clinical scenario.
Can we have details of the case?
Clinical details.
Hello, can we have clinical details of the case?
The next case is a 55-year-old lady who presented with history of jaundice of 10 days duration.
and high colored urine associated with intermittent abdominal pain and vomiting. So clinically she looked pale and interest was there. Abdominal examination, she had mild epigastric tenderness. Her hemoglobin was 9.8 grams. And bilirubin was 10.7, direct bilirubin of 7.1, and alkaline phosphatase of 383 international units with normal transaminases. Her ultrasound showed contracted gallbladder, moderate IHBD with dilated CHD and normal CBD, suggestive of obstruction at CHD-CBD junction probably. Maybe a benign or malignant structure. So,
Krishna Institute of Medical Sciences, we are conducting an ENDOLIVE
For you all, that will start the next topic at 2:40.
for the Krishna Institute of Medical Sciences. Today we are conducting a ENDOLIVE workshop on gastroenterology department. Most of the people in long standing how to do an endoscopy and the colonoscopy, and then there are some therapeutic procedures like ERCP where there is a large stones, and then how to bring out those stones out of the bile duct and pancreas so that we can cure those diseases, so we can prevent the cholecystitis and other things. Those patients, and when we want to do a proper, we have gathered all the national, international experienced gastroenterologists, had a thorough workshop on these things, and then they have performed nearly 20 live cases, and so that there is a lot of discussion as went on, and so that everybody will get benefit. Ultimately this benefit will pass on to the patients.
Gastroenterology as a specialty relies heavily on use of endoscopy for diagnostics and treatment. It forms a very vital part of the specialty. What we've done here for today and tomorrow, it's a 2-day workshop going from basic endoscopy that's required for simple diagnostics to the most advanced forms of endoscopy which can be used to deliver some treatments and in some cases avoid the need for surgery even. So we're going to showcase these different levels of endoscopy over today and tomorrow, and it's a team effort. It's a team effort on the part of the gastroenterology team at KIMS, including the medics and the surgeons, and also the whole Hyderabad gastroenterology community has gratefully come forward. They've magnanimously come forward to take part in it on a working day. We've had very good attendance today. There's been a lot of discussion during the morning sessions, a lot of exchange of ideas, and this is an essential part of ongoing medical education. So irrespective of how experienced you are, how long you've been practicing the specialty, it is important to keep yourself updated, and that is the effort today. And in the end, we all hope that we'll be able to deliver cost effective care to our patients.